Can everyone see my slide?
Yes, boleh nampak. Boleh clear.
Okay, alright.
I think kalau everything ready, I think kita start sekarang lah. Ya, Assalamualaikum warahmatullahi wabarakatuh. Good morning to everyone. Welcome to our CME today. The title will be Parasomnia. We are honored today to have Prof. Syed to join us as one of the presenter. So Prof. Syed will not need a long introduction. Prof. Syed is currently retired, a consultant psychiatrist, currently doing sessional clinic in UPSC, UiTM's private specialist center. Prior to that, he worked in UiTM, Unimas, as well as UKM. So how we're going to do CME today? So we're going to start with the case presentation by Dr. Shahrin. Then I'm going to go through the sleep report, and later on, Prof. Syed going to comment on the case presentation as well as the sleep report, and share his previous experience in managing patients with similar presentation. So without further ado, I would like to invite Dr. Shahrin to start the case presentation.
Okay, Assalamualaikum and good morning everyone. My name is Syarin. I'm at year 4. So today I'll be presenting on a case presentation of which we saw in our clinic about early this month. So without further ado, so this is the background history of the patient, Madam AC. She's a 35 years old staff nurse in HKL. She was diagnosed with MDD, with borderline personality disorder in 2016. Back to the history wise, she first complained of vivid nightmares since early last year. Starting this year, the nightmare turned into night terror. She's able to remember details of the nightmare, mostly constitute of ghosts and her late father. For example, there is one occasion whereby she said that she's being chased by ghosts, and then there's another occasion whereby she saw her late father whom give her instruction to come with him until to the point that she nearly jumped from her balcony. She's able to remember details of her of her dream. It got worse after changes in the medication by the PSY, whereby she started to sleepwalk and started harming herself and others. The most terrible thing that happened was that number one, she accidentally choked her daughter in her sleep. She wasn't able to recall, and then she's only able to wake up after being called by her husband repeatedly. Second thing, she sleepwalked and found herself in the toilet, started harming herself. She had a lot of wound on her wrist. There is one occasion whereby her husband need to restrain her at night with padlock, and despite that, there's a wound she managed to inflict. I don't know whether she or somebody, there's an inflicted wound on her right thigh, at that particular of time. Because it got worse, she was hospitalized at that particular of time in HKL. So this is the medication history timeline. When she was first diagnosed with MDD, she was started on escitalopram, and then in 2021, when this thing occurs, there's a lot of medication changes along the way. In March, it was when the sleepwalk occurs. We can see that the psychiatry doctor are having a hard time in stabilizing her medication. In July, when things got worse, she was hospitalized, and then lastly, she was started on Pristic and mirtazapine. However, because she was planned to be referred to us for sleep study, PS psychiatry team is trying to minimalize her medication. So she did a PSG, I think 2 weeks ago, and Dr. Amin, I will pass on to Dr. Amin to explain in terms of the sleep study report. Thank you.
Okay, thank you, Dr. Shahrin, for the case presentation. There are a few terminology and that we just heard just now is dream, nightmare, sleep terror, sleepwalking. I think Prof. Syed going to delve further. of the definition just we just shared just now. So I'm going to describe the sleep report that we just performed about 2 weeks ago. So patient was referred to our clinic. The reason for the referral, whether patient have sleep disorder. So whether the sleep disorder is due to the underlying psychiatric problem that patient have, or is it a part because of the multiple drugs that patient receive to treat her underlying psychiatric disorder. So, so I'm going to describe the sleep report. Do you manage to see my screen?
Yes.
Can you see my screen? So we start from the to the indication. So just to recap what Dr. Syarin mentioned just now, a 36-year-old female Iban was referred for full overnight video polysomnography, another term for sleep study. Full. So we have the things that we do is full sleep study, full polysomnography with addition of video during the sleep study. The reason is to rule out REM, sleep behavior disorder lah. I think the history Dr. Syarin already mentioned, patient have MDD since 2016 with nightmare, sleepwalking, and history of harming herself. Patient on multiple psychiatric medication. For the purpose of the study, we stop patient only medication at that time is Pistic. We stop Pistic 24 hours prior to the sleep study. Okay. So I'm going to go through the sleep report. So the test was performed on the 26th July, 2 weeks ago. We look at the total sleep time. It's about 7 hours, 29 minutes, more than 6 hours. Sleep latency, sleep efficiency, we're looking more than 85%. So patient is 97%, good sleep efficiency. Then we look at the sleep latency, how many minutes or what is the duration patient required to sleep. So is reduced but 2 minutes. And REM latency bit prolonged, normal is between 90 to 120. For this patient is 173 minutes. We look at the sleep architecture. N1 is about 8.8%, normal is about 5%. N2 is between 45 to 55, so patient within the normal range. N3, normal is 20 to 35, patient is only about 15%. And REM sleep is between 20 to 25 again. REM sleep is within the normal limit. We look at the sleep henogram. So you can see patient have 3 REM cycle throughout the night. So normal is between 3 to 5, and the normal pattern is stage 1, 2, 3, and REM sleep. So patient have normal sleep architecture. In fact, during the sleep cycle, there's no fragmentation. You look at the respiratory event during the in the hemanogram. So there's no apnea or hypopnea on the hemanogram. In fact, there's no desaturation during the sleep. Now we look at the respiratory event itself. The total event, apnea and hypopnea throughout the night is about 14 event, giving 1.9 event per hour atau 1.9 per hour lah. Call it total apnea hypopnea index. So less than 5 is normal. There's no snore. In fact, the lower saturation is about 93% normal. So total predictly movement is still about 7 event, giving 0.9 event per hour. Patient sleep position is almost half-half, supine and non-supine. During the sleep, we don't monitor the CO2. For that reason, the value in this parameter is absent. So what we know from the sleep parameter, patient have reduced sleep latency. Normally in I think Prof. Syed going to explain further, during patients who have depression, the sleep latency is prolonged. The REM latency is slightly prolonged. It's 173 minutes. Normally it's within 90 to 120. In terms of sleep architecture, if REM sleep and non-REM sleep normal. There's no respiratory event. There's no oxygen desaturation. There's no periodic limb movement during sleep. So throughout the night, during our video recording, there's no sleepwalking noted during the recording. Because the question is whether patient have a REM sleep disorder. So one of the things that we look for REM sleep disorder is we are looking at REM sleep without atonia. So there are few specific sleep epoch during the sleep recording that may indicates this happen. So this is one of the sleep epoch, epoch number 399. So during this epoch, patient REM sleep. How do we know REM sleep? So just let me orientate you to the parameters of this epoch. So on the top is the eye movement. So this represent the right ocular right eye. The second line represent the left eye. Then the EEG recording, the next 6 channel, and this is the chin movement. Can you see the sleep epoch?
Yep.
Okay. So in REM sleep disorder, we are looking at the REM sleep without atonia. So just repeat myself again. So in this sleep epoch, there are few parameters that we look for. So the first 2 lines refer to eye movement. The first line is right eye. The second line is the left eye. Then 6 EEG parameter. This is chin channel. Then following that is the right and left leg. So ideally, normally for rapid eye movement, you can see the rapid eye movement, but in this epoch, you can there's no rapid eye movement. But prior to this epoch is a REM sleep. So you can refer to this REM sleep. So typical REM sleep, we have sawtooth appearance, low amplitude EEG, and normally during REM sleep, there's no motor movement in the chin or the leg channel. So, but in this epoch, we can see there is a chin movement. So there is REM sleep without atonia. Second epoch is epoch number 637. So again, you can see the first 2 channel represent the eye movement, so the typical rapid eye movement, and rapid eye movement. EEG is sawtooth appearance, EEG, REM sleep. So again, you can see this time the leg channel, you can see there is motor movement. There's no atonia. There is movement in the leg during the REM sleep. Next epoch is epoch number 673. Again, a typical rapid eye movement, the first 2 channel. Then sawtooth appearance of the EEG during REM sleep. Again, this time the blue color, if you can appreciate, is the leg movement. There is no atonia during sleep. So rapid eye movement sleep stage, but without atonia. And the last epoch, epoch number 874. You can see there is a rapid eye movement, EEG. You can see there is at this point chin channel. You can see there is atonia. There's movement in the chin channel. So what we can found in this sleep study, there are few epochs that show rapid eye movement sleep without atonia on the chin and the leg channel. The question now, whether during this epoch, patient have a REM sleep disorder. In terms of the video recording throughout the night, we cannot capture any movement during the sleep record. Then I pass the presentation to Prof. Syed to elaborate on the case discussion as well as the sleep report. Prof. Syed?
Okay. Thank you, Dr. Amin. Number one, I'd like to say a big thank you to all of you who have contributed to this case. I just want to make a few comments. Number one, regarding this occupation of the patient, staff nurse in HKL. Number one, you need to understand how stressful it can be for someone in the medical field, especially in HKL. And being a staff nurse, if she's on the rota system, that means she's working at different hours shift duty. That can also affect to some extent the quality of her sleep, number one. Number two, you mentioned she has MDD, which is a major depressive disorder. And there are two types. One is typical, one is atypical. Typical, they tend to have insomnia. That means there is insufficient sleep. Whereas atypical, they sleep more than usual. That is, they can hypersomnia instead of insomnia. So if you want to know why the sleep latency is shortened, question is whether she has atypical type of depression rather than typical type of depression. That's one thing. The other one, you also mentioned about, in addition to MDD, she has borderline personality disorder. You need to understand what is meant by borderline personality disorder. These are people commonly in women, and they have a very significant history of childhood problem, either being neglected or being emotionally disturbed, physically, emotionally abused during childhood. And when they grow up, they tend to have problem with interpersonal relationship. They cannot establish a good, mature interpersonal relationship. They tend to get very depressed very easily. They're very vulnerable to depression. The other one, borderline personality, they tend to harm themselves. They tend to inflict injury. You can see them in adolescent stage, either they cut their wrist, they take an overdose, they do all sorts of things, they burn themselves with cigarette butts and so on. And the other one, there's also a tendency for them to abuse substances like amphetamine, ice, shabu, cannabis, and so on. So you look at the personality profile, borderline personality, it has its own constituents of abnormalities there. And so in addition, she has MDD, she has borderline personality, work problem if there is one. That's why in history, it is very important to go a bit thorough to know what is the socio-economic status of this patient, what is the psychological background, what is the home environment, what is the dynamic relationship in the family. You mentioned she tried to choke her daughter. We want to know how many children does she have? She has. And how old is the child? Is the child schooling? Is the child doing all right in school or not? Because all these are circumstances which can affect the emotion of this particular patient. So that's why you want to go a bit more into the history. And then this is a long history of emotional problem back to 2016. It's about 6 years already. So it depends on what kind of medication she was on, whether she has shown any remission, any relapse, or so on. Because if there is a relapse in MDD, the next relapse is very high. The more relapse she has, the higher the possibility of she getting more and more depressive disorder and more difficult to treat sometimes. There is such a term as treatment-resistant depression, where you can use all the medication you have, but you find it's very difficult for them to get a full remission in the situation. So that is something that you have to think about. Then you begin, she was started with Lexapro, with escitalopram, which is a good medication. It is an SSRI. It builds up serotonin in the brain. That is okay, acceptable. And then you also mentioned about nightmares in 2021 last year. Now, I told Amin yesterday, dream is normal, nightmare is abnormal, especially if it is a consistent theme all the way and it's quite frequent. And she's nightmare of ghost, something which is horrid and negative, fearful to her, and about her late father. Again, we want to know to the dynamics. Sometimes people can have some guilt feelings toward relative who has passed away. Either they have not done enough for the person who has passed away, their loved ones, then there's a lot of guilt inside them. And this also sometime or other can aggravate the emotional status of the person. So that's why I said you have to be very thorough in terms of history so that you want to know all the predisposing, the precipitating, the perpetuating factors in this patient. And also you want to explore what are the protective factors in this patient. So that is quite important. Then you also mentioned that from nightmares 2021, she goes on to night terrors. Night terrors, basically, there's a lot of screaming going on with this night terrors, and especially in children. Very difficult for you to communicate with the patient during night terrors. And it's total amnesia the next morning. And it doesn't last very long. It's a few minutes and then they just go back to sleep quietly, not disturbing anybody else. So question is whether it is really night terror or is it part and parcel of the consequences of the nightmare that she has at that particular point in time. But you must know night terrors do occur sometimes together with sleepwalking in some cases. Very worrying situation like jumping from the balcony. That can be very dangerous. It does happen. I will show you some case which I have presented at the Congress of Asian Pacific Society of Respiratory about 7 years ago. I had 3 cases I given to Amin, and one of them involves sleepwalking, another one is confusional state, another one is REM sleep behavior disorder. I can tell you after we have discussed this particular case that we are doing at the moment. And the other one is we want to know whether this is a consequences of her waking up from the dream or not. Because we are going to 2 particular areas here. Number 1, are we dealing with sleepwalking or are we dealing with REM sleep behavior disorder? So this particular 2 things we have to distinguish. So we are lucky we have the polysomnogram on board. At least it can tell us to some extent what it is all about. If it is purely REM sleep behavior disorder, the consequences of the behavior is related and linked to the content of the nightmare that they have. So if they dream they are in a fighting mood, they will show those kind of things. They think they are being chased, they tend to show so kind of similar situation. So that's why you have to go a bit more detail the content of the nightmare that she was having, which is also quite important. The other one, when you want to know the sleep disorder, it's very important to know the last incident of the sleep disorder. It can be sleepwalking, can the REM behavior sleep disorder, or is it nightmare? You want to know the final one, that when you focus on the final one, because the final one will give you some idea what is the current status at the moment. So she was done polysomnogram recently, and it's good to know before you start the polysomnogram, when was the last one that she has had? Either it is REM sleep behavior kind of symptom, or is it sleepwalking kind of symptom, or is it nightmare kind of symptom, night terror, that will give you an idea what is the most significant situation at this particular point in time. And the other one, when Amin did the polysomnogram, he off the pre-stick 24 hours. If you off longer, that will be better because it will clear up from the body much better. But it is luckily she doesn't show any flare-up of symptom even you have stopped it for 24 hours. And we want to know if she goes back from the sleep lab at home, whether she continue back on the pre-stick or she is withhold the pre-stick. If she withhold the pre-stick, it's good to know whether those incidents of sleep disorder has come back or they have disappeared. we want to know about that. If he goes back to the pristic, also we want to know whether the sleep disorder has come back or disappeared. Here we are trying to link whether the thing that precipitate the sleep disorder is because of medication or because of something else. We do not know. So the history will give you an idea what it's all about. Okay, and history of harming herself also again. Now we have to look back into the personality of the person as well. You cannot ignore that. You want to know the home environment, interpersonal relationship, socioeconomic status, and so on. And restraint here, I don't think my feeling, it may not be tying the patient onto the bed, but probably they lock the door to prevent her from going out from the door. I think that would be more reasonable to me lah. I do not know. I mean, this is my speculation. No husband will restrain their husband in the bed. I think the husband is asking for trouble the next day if he do that lah. So I don't think about that. I think maybe they lock the door. That's okay. You need to do that because you don't want any harm to happen to anybody. There's a wound on the right thigh. Again, what causes the wound on the right thigh? Is it self-inflicted or is it some kind of some struggle going on? We do not know. So good to know a bit more history into this patient. And then she was added some other medication as well. One of them is Remeron, which is metrazapine. If you look at the literature under Pristic put a big contraindication between Remeron and Pristic. You do not use Remeron and Pristic together. It's not good. So luckily, the doctor has removed the Remeron after about a month or so, I think, which is good. You don't combine because Pristic has a lot of caution with other medication as well. So you have to be very careful. You can read the literature. There are a big, long list of medication, which is you have to be careful when you use Pristic. This is venlafaxine. So you have to look at that. She was put on clonazepam. Clonazepam actually is a benzodiazepine. It is recommended people as well. If you look into the literature, people with restless leg syndrome, for example, clonazepam has been recommended. I think it's a good drug, but it was taken off. I do not know what's the dosage was given, how long it was given, because if you look at the situation at the moment with history of self-injury and all these things, I think benzodiazepine can be useful. It's useful. I won't hesitate to give even lorazepam, which is Ativan, which can be very useful as a sedative for this patient. It can help to improve the quality of sleep to some extent, and then it can make patient restless, less fearful, less anxious, and probably she can adapt better to the home environment. That's what this is all about. Now let's look at the polysonogram. A typical polysonogram which indicates major depressive disorder have a few criteria. This has been established in the literature. Number one, there is an early onset REM. REM comes about 90 minutes or so after the patient falls asleep. But people with MDD, the REM can come even about 30 minutes after going to sleep. So early onset of REM is number one. But this one, the onset is normal, not that early. Number two, there is very dense REM. REM here about 25%, which is normal. People with MDD, the REM can go up to 50%. And then number three, there is very reduced stage 3 and stage 4 sleep. So if you have a polysonogram with someone with early onset REM, very dense REM, and very low stage 3, stage 4, that is a biological marker for major depressive disorder. You don't see in this patient. Why? Because patient is already on treatment. So she may have already recovered to some extent, may not be fully recovered, but from the polysonogram, it shows that at the current point in time, you don't see so much symptom of MDD in this patient if she is compliant to medication. The rest of the sleep architecture are okay. The only thing I want to mention is about the REM sleep and the atonia. From what Amin is saying, there are evidence of muscle movement here during the REM sleep. Technically, you don't expect that to happen. You should see atonia, but in this case, you do see some muscle movement here. This is already after patient on medication. You have stopped the medication, whatever it is. So you can speculate. Is it possible at home when she was having all this sleep disorder during the REM sleep? Because I'm very concerned about, number one, the seriousness of the nightmare, the content. Number two, seriousness of the behavior after that. And then could that be related to REM sleep behavior disorder, more significant than the sleepwalking itself in this patient? So that is sleepwalking. They tend to come back to the bed after some time. That the sleepwalking. Whereas REM sleep behavior, there's a lot of commotion after that, and then patient will start asking a lot of questions. What is happening? What is happening, and so on. So that is on the polysomnogram, which is a good report, and it helps us in terms of the diagnosis of the patients. So if you ask a question, where do you want to put the diagnosis? Is it MDD with sleepwalking? Number one. Number two, MDD with REM sleep behavior disorder. So based on those things, you want to put into a vote, we can put into a vote if you want to, but it is up to you to make up your own mind. But to me, indications are, it looks more like REM sleep behavior disorder to me. But we cannot rule out sleepwalking as well, because it can happen together as well. Because diagnosis here, he has symptom of both, a little bit of here and a little bit of that. So what's important now, how do we take care of this patient? At the moment, if the history is that she has lost some of this sleep behavior, sleep disorder, and it's good. And regarding the pristic, again, we want to go back. It was withhold 24 hours before the polysomnogram. Whether she goes back from the sleep lab, did she withhold the medication or she continue the medication, and what is her emotional status at the current point in time. If we say the problem is because the pristic, then we need to change to another antidepressant. There are many more in the market which is available. So you have started some already. There are many more in the market. You may have to combine the medication to some extent in this patient. More important is in terms of the background of the patient. I believe very strongly in terms of looking into the personal situation of the patient. I believe in psychotherapy. You have to, she need a lot of supportive psychotherapy regarding whether stresses at place of work, the dynamics in the family, and what is her relationship to her late father, and how are these things evolving slowly over a period of time. And then genetics. I have come across people with sleepwalking. Mother is sleepwalking, father is sleep talking, and grandson is bruxism. It runs in the family. All this parasomnia runs in the family. But eventually they will get over it. And if you occasional attack, you don't have to give any medication. But if it is prolonged, it causes some injuries, then you have to do something about it. And that's how we look at it. So that will be my comments on this case. I leave it to Amin, whether you want me to go back to the 3 cases which I presented at the Congress of Asian Pacific Society of Respirology, or you want to ask questions now. What you want to do, Amin?
Okay. Maybe we allow any question for the audience before Prof. Syed share these 3 cases. Any question from the audience regarding the case presentation or the sleep report just now, and Prof. Syed comment? Any question? Yeah. If not, then we can continue with the 3 cases, Prof. Syed.
Okay, these 3 cases I presented on parasomnia about 7 years ago at the KL conference. We look at the DSM-5. There are disorders with abnormal behavior occurring in sleep. Most common are non-REM sleep arousal, which is you are talking about sleep walking just now, Then REM sleep behavior disorder. I will give 3 examples on these 3 cases. Number 1 is non-sleep arousal disorder, the sleepwalking and sleep terrors. The other one, REM sleep behavior disorders and confusional arousals. These 3, we were talking about that. Now, the first case about sleepwalking, this is a 40-year-old man with a bipolar mood disorder, treated in 2005 with olanzapine, which is antipsychotic, chlorpromazine, which is also antipsychotic, epilim, which is a mood stabilizer. He's a foreigner, he's at US, he's an American, he's a businessman. I first saw him in Selayang Hospital in 2009, and I give him the Syriquel, which is another antipsychotic. I switched the medication and add on clonazepam, only 2 medication. So 1 year later, I added zolpidem because he complained of insomnia. And then in April 2012, he developed sciatica, and so he was given tramadol for that sciatica. And he went overseas in 2012 for a new job. And in 2012, when he was in Manila because of his job there, he fell during the sleep and sustained right neck humerus closed fracture. I'm asking myself whether this is related to sleepwalking or not. The man developed a fracture, right neck humerus, closed fracture, and whether this is related to sleepwalking or not, I do not know. That happened in Manila in 2012. And then in October, this is where it started when he was in KL. He was unaware, but the wife noticed. During sleep, he went to the kitchen, he boiled a pot of oil, and then he went back to bed. But the wife followed him all the way. So he was unaware of what was happening. So this is a good case of sleepwalking. Unfortunately, we do not do any polysonogram with him at that time. And if you ask me, why did all these things happen? Some medication do produce this kind of situation. And Stilnox sometimes do produce this kind of situation. Stilnox can also produce hallucination in some patients. So it depends on the patient's idiosyncrasy. Some people will show this kind of response, some people will not show this kind of response. It's not a blanket kind of situation. So in 2013, he developed seizures. Now, one of the differential for people with sleepwalking or REM behavior sleep disorder or night terror is to rule out nocturnal epilepsy. So when you do your polysonogram, you don't see spikes and waves, then you can say this is probably not nocturnal seizure. But you have to rule that out as well, as possibility. So in August 2015, he went back to USA. He was continuing with Syriquel. He was put on temazepam, which is Nomison and tramadol. And then 2015, he's back on Syriquel, no more sleepwalking. So it was 1 episode which I saw, and which is also registered by the wife, and 1 episode of a fracture of the humerus. So I'm asking myself, could this be an evidence of sleepwalking? So that's number 1. Number 2 is the REM sleep behavior disorder. This happened to a first-year college student. It's a gentleman. He was charged with trespassing into the female hostel and assaulting a female student at 3 in the morning. And then the student said he did not know what happened, but admitted he went to the hostel. He admitted he did went to the hostel. He did go to the hostel. So he claimed he was dreaming about a thing that went to the hostel that assaulted the student. So he said when he opened his eyes following the dream, he saw something and he followed that object into the woman's hostel. And upon awakening, he wanted to confirm what he dreamt. Question to me then was could this be a REM sleep behavior disorder? Because it is linked very closely to the dream that he has. And then when he opened up his eyes, he tend to do what the dream was all about. Then this is something which he has violated the university disciplinary board situation. So the university wants to know whether that was deliberately done or is it because of underlying some kind of sleep disorder. If it is due to sleep disorder, then he's not accountable. He needs help. If it is intentionally done, then should be punished, because that is something that he know what was going on. He know the consequences of what he was doing. So again, question here. Unfortunately, again, we do not do the polysomnogram on him, but this is a story. But if you work very closely, sounds like REM sleep behavior disorder, but you need to explore further what actually happened with this boy. And this is one second situation. So the background of this student is that he's academically good student, was a school prefect, very sociable person, middle class family, no family history of mental illness, good family support. So not much stress in this particular person. Why is this thing happening? A lot of questions need to be answered regarding this point. I leave it to you to decide whether you think this is a REM sleep behavior disorder or you think this is intentionally done. But you might be surprised that he went to approach the family of this girl, and he even proposed marriage to this girl. So that was another story. So it's very interesting when you do sleep study and you are a psychiatrist, you see all sorts of things, what's happening in the society. Now I want to move to the third one, which is confusional arousal. This is about the story of a 27-year-old policeman charged with murder and alleged to have shot his roommate. Following a police raid that evening, he returned home about 4 in the morning, carrying his revolver home, and he placed his gun under his pillow. And then he shared the same bed with his roommate who was sleeping beside him, another male policeman. About 5:30 in the morning, he heard a shot. And on awakening, he saw his roommate with gunshot in the head and was dead. And because of that, he was charged with murder. Question is this deliberate or is this because of sleep disorder? Again, the judge will want to know. It's our job to give opinion on clinical grounds. We don't tell the judge whether he's guilty or not guilty. We tell the judge on clinical ground what is the problem with this man. So here in confusional state arousal, the patient has no evidence of dream. He said he did not dream anything at all at that particular night. And he was in a shock what actually happened. He just cannot accept what happened. The roommate and him, they were good friends. No rivalry, no family history of psychological disorders, and patient was remorseful after that. So this is an example of confusional arousal. So whether the court will buy our recommendation or not is up to them. If the court buy our recommendation, then he will be sent to a hospital so that he goes under proper treatment, so that he recover, and then when he's okay, he can be discharged. If the court doesn't buy our argument, if the court says this is criminal behavior, then he's answerable to that. So based on these things, the court will have the final say. Our job is just to recommend. So these three cases I want to share with you. Number one is the sleepwalking. Number two is the REM sleep behavior disorder. And number three, the confusional state. They have some relevance to the case that you have just discussed just now. Any question Amin, back to you.
Okay, thank you, Prof, for the case sharing. So I think any patient that we encounter with similar presentation, there are few differential diagnoses that we have to entertain. As Dr. Prof rightly mentioned, we have to go through the history a bit in detail to make sure that we capture all the important presentation as well as the patient so-called social background, and hopefully based on the thorough history we can narrow down our differential diagnosis, and hopefully the sleep study with the video will support the differential diagnosis that we like to entertain. Any question from the rest of the audience? If not, I think we almost towards the end of our CME session today. If not, we like to thank Prof. Syed for the discussion. What we're going to do for our case today, we're going to re-review her case again. As Prof. Syed mentioned, we have to explore further whether the symptom reoccur after the cessation of the prick or reoccur after resuming the prick. From there we can decide lah, do we need to repeat the sleep study again or not. Thank you, Project. Thank you
Thank
for
you
the
so much.
audience.
Thank you so much. Most welcome. Okay.
Okay, Assalamualaikum warahmatullahi wabarakatuh.
Assalamualaikum warahmatullahi.